Thank you very much. Next, we have Dr. Michael Wasserman, who's the past president of the California Association of Long-Term Care Medicine. Dr. Wasserman.
Thank you. Chairman Ting, committee members, those who say we didn't know what was coming to nursing homes in March and April weren't listening to the experts in geriatrics and long-term care medicine. On March 9th, I told NBC News that the coronavirus was the greatest threat to nursing home residents that we have seen. On March 25th, I told CBS that nursing homes could become our killing fields. My experience as a clinical and quality expert, in addition to having been the CEO of the largest nursing home chain in California, gave me a unique perspective into COVID-19 and the measures that need to be taken to reduce its impact and devastation. I want to thank Assemblyman Wood for bringing AB 2644 into law. Its requirement of a full-time equivalent of an infection preventionist in every nursing home is the type of workforce change that is necessary to protect vulnerable nursing home residents. But it's only the beginning. I come here today as immediate past president of the California Association of Long-Term Care Medicine and current chair of our Public Policy Committee to make recommendations that are actionable and sustainable as we move forward. Today's nursing homes are essentially mini hospitals, regardless of whether they deliver post-acute care or provide long-term care to the most frail, complex, and challenging population of patients in our history. The average nursing home resident has multiple chronic conditions, cognitive impairment, and requires professional oversight and care from a broad array of caregivers and healthcare professionals. Historically, a major role of the nursing home administrator has been to put heads in beds. The medical director, by federal regulation, is supposed to be the clinical leader of a nursing home. In usual practice, unfortunately, medical directors are often separated from clinical policy discussions and decisions. Registered nurses, as professionals who are trained to assess patients, are sometimes not available to make necessary assessments in real time. How do we run mini hospitals without the clinical leadership and staffing that are so vital? COVID-19 has brutally exposed this weakness. There is now ample literature to demonstrate that 24-hour RN coverage and a minimum of 45 minutes of RN staffing per resident per day, along with enough LVN and CNA coverage, leads to fewer COVID-19 outbreaks and deaths. Consultant pharmacists must also be engaged to the fullest extent. I can tell you, based on over 30 years of experience in the field of geriatrics, that having a competent and engaged medical director to work with the nursing staff and the infection preventionist, as well as to guide administrators who have little clinical expertise, has played an important role in battling this scourge throughout the state and country. I am a faculty member for the American Board of Post-Acute and Long-Term Care Medical Director Certification course, as I recently participated in the 3-day course that completes the training. All I could think of was what a difference it would have made if every nursing home in the state had a certified medical director over the past 8 months. I guarantee you that if that had been the case, and in conjunction with the appropriate nurse staffing levels, far fewer nursing home residents would have died. Every nursing home in the state already has a medical director, and nursing home owners already spend a significant amount of money on medical director stipends. By requiring certification, you will assure that nursing home medical directors have the tools, the skills, and the professional obligation to provide qualified oversight. This will not increase costs to the state or the industry, but it will improve quality and accountability. There is also evidence-based literature that demonstrates a correlation between for-profit status and the size of COVID-19 outbreaks and deaths. The motivation for profit must sometimes be reined in to avoid harming the customer. Manipulation of existing related party transaction reporting can also skew actual facility level profitability. This is why we must have complete transparency around the ownership structure, as well as giving strong consideration to a medical loss ratio parameter for nursing homes. Last, but certainly not least, CNAs, the true heroes of this pandemic, must be treated with the respect and dignity they so richly deserve and finally earn a living wage. I also encourage you to pay extra attention to the comments of Nicole Howe and Dr. Charlene Harrington. I respect and value their insight and opinions. Thank you for this opportunity, and I look forward to answering your questions.
Thank you, Dr. Wasserman. Could we have